let me set the stage. So in 2005, the College of Nursing and the College of Dentistry became organizational partners, which created a unique opportunity inspired by a vision to capitalize on this new, unique partnership, the only one of its kind in the country, to take the opportunity to seize the moment, carpe diem, if you will, to create a sea change in how we conceptualize, and that was before the term interprofessional became the buzzword of the day, but to inspire creativity around collaboration, interdisciplinary partnerships, and an opportunity to change the way we practice, an oral health call to action, if you will. It was really a unique opportunity because all too often, as many of us know, and if you haven't thought about it, this morning is an opportunity to think about it, the mouth is a forgotten part of the body. It's even a forgotten part of the head. But, as we know, it is related to oral health in a significant way and general health. So, in 2000, the Surgeon General's report was really the first major document that called attention to the mouth as a window to the whole body. That report, while lauded in healthcare circles, did not gain much traction. And the whole notion of integrating oral health into overall health practice by the non-dental community didn't happen in any major way. Probably the area where it happened to the greatest extent was in pediatrics. And the water fluoridation, the fluoride varnish application, and so on, was the most significant change in practice among primary care providers. However, in 2011 and 2012, three important documents were published by the IOM. Two IOM reports about advancing oral health in America and building workforce in terms of oral health, and an oral health literacy report. Those three documents have had a significant impact on calling attention to the importance of oral health, not only for the dental community, because that's preaching to the choir, but to all of us who are non-dental providers. And actually, the most significant, almost co-occurring event was the publication in 2011 of what we fondly call the IPEC competencies. These are the interprofessional education collaborative practice competencies that were forged through the work of 6 of our professional organizations, including the American Association of Colleges of Nursing, the American Dental Education Association, AAMC, which is the Medical Education Association, the Pharmacy Association, Public Health, and the osteopathy organization. That has really been a key factor in propelling the interest in interprofessionalism that has lit the fire across the country. One of the recommendations of the IOM reports was for HRSA to convene an expert panel to develop interprofessional core competencies, oral health core competencies for primary care providers. And I was fortunate enough, because of our situation at NYU, our unique situation, to be a member of that expert panel, which did have interprofessional representation. The innovation we have created as a result of the HRSA report on integration of oral health and primary care practice was to coin a term that is becoming nationally recognized. We have transformed the HEENT exam, which we all learned in physical assessment, to the HE-NOT exam. When you use the HE-NOT approach, you cannot forget about oral health, whether you like it or not. As you do your health history and integrate oral health considerations into that, or you conduct your physical exam and think not only about the oral cavity now, but think about its relation to the rest of the exam that you're doing, which is reflected in the risk assessment that we all do after we've completed the history and physical. And then an action plan, to develop an action plan, which for us as primary care providers or even as acute care providers, largely focuses on preventive interventions within our scope of practice. We are certainly not interested in becoming dental nurse practitioners. That is not our aim. We have the collaboration and referral opportunities with our dental colleagues, many of whom have joined us today, to close the loop on increasing access to oral health care. So one of the things that I really want to emphasize before we invite our first presenter up is that our involvement in oral health is really about three things. It's about increasing our knowledge base and our clinical competencies, which we're here to do today. It's also about creating a change in practice as we think about our practice and integrating oral health into our practice, and then sharing that knowledge to make sure our students who are being bludgeoned to death with oral health considerations, that they actually transfer what they're learning in the classroom and in the simulation lab into their clinical practice. So it is reflective of holistic oral systemic health practice, whether it's primary care or acute care focused, and that we collaborate with and refer to our colleagues in the dental profession. So this is all about building workforce capacity in primary care, which through interprofessional education and practice, hopefully will decrease health disparities by increasing access to health care, oral health care, and general health care, and eventually improving outcomes, both oral health outcomes and general health outcomes for populations across the lifespan. And with that, I'm going to turn the program over to Erin Hartnett, who is the marvelous leader of the team that organized this Preceptor workshop, and I'd like everybody to give her a hand because she and her team, Yanina Babuka and Abigail, come on out, Bella, have done a sensational job in organizing this wonderful workshop this morning. Take it away, Erin.
All right, thank you. Thank you all for coming. It's great to see so many of you here. And as Judy said, we have taken this call to action very seriously here at NYU College of Nursing. We really believe that the way to improve the oral health of our patients and our population is to increase the workforce capacity, decrease the health disparities by educating our nurse practitioners, because they are on the front line. They're there, they're looking in patients' mouths every day, and they need to know what they need to look for. So what we've done here at NYU is we've integrated oral health throughout our curriculum. It's in our core courses, our advanced core courses, and all of our population courses in the diagnosis and management assessment courses. So our students have the knowledge now, and we want to be sure that they're able to use this when they're out in the clinical area. But we realize that many of you may not have had any or very little oral health education in your nursing programs. So we want to share with you today how you can integrate oral health into your clinical area in your population, how you can recognize some oral systemic connections, and how you can help the nurse practitioner students and yourself in the role of the nurse practitioner in prevention, in management and monitoring some of the oral systemic connections, and in collaborating with our dental professionals and referring to them. So today we've assembled a wonderful panel here, an interprofessional panel of experts, and we go from pregnancy to end of life. And I'd just like to introduce everyone here. First, we have Dr. Julia Lange Kessler. Julia is the coordinator of our midwifery program, and she will talk about oral health in pregnancy. Okay. Right after that, we have Dr. Amr Moursi. Dr. Moursi is the chairman of pediatric dentistry at the NYU College of Dentistry, and he'll give us an overview of how dental care is actually developed. After that, we have Dr. Donna Hallas. Dr. Hallas is a pediatric nurse practitioner, and she'll present the management and assessment of children, infants and children in oral health. And Dr. Hallas coordinates the pediatric nurse practitioner program. And then we have another colleague from the dental school, Jill Fernandez. Jill is a dental hygienist, but she coordinates the dental outreach program at the School of Dentistry. And Madeline Lloyd. Madeline is a family nurse practitioner, and she works at our nursing faculty practice, which is actually located in the dental school. And she'll be giving us an overview of adult oral health. And Dr. Mark Wolff, he is our dental colleague from the NYU School of Dentistry. He's the chair of Cariology, and he's an expert in geriatric oral health. Next, we have Dr. Candice Knight. And Dr. Knight is the coordinator of our mental health program, and she'll be giving us an overview of oral health in the patient with mental health issues. And then Dr. Mary Brennan. And Dr. Brennan is an acute care nurse practitioner who coordinates our acute care program, and she'll be giving us an overview of the hospitalized patient and their oral needs. And then we'll finish with Dr. Dorothy Wholihan, and she'll tell us all about the needs in the end of life with her. She coordinates the palliative care program. So after we get all of this, I'm hoping you'll all see how you can fit it into your program. Each of the panelists will join you at the table. We'll have case studies. You'll be able to discuss how you can implement it in your program. And we have standardized patients coming, and they'll be at your table so that you can practice the oral exam, learn how to do it. We have tooth models that we'll put on the table so you can practice fluoride varnish. For the pediatric people, we can't have children come in, so we do have a mannequin, a pediatric mannequin with oral pathologies. So I think you'll find it a lot of fun and interesting, and there'll be a lot of discussion, and you can ask the experts at your table whatever you need. Okay, so we'd like to get started with yeah, come up here so you can use this. Okay. So you can just click it, or if you wanted to move around, you can use that mic.
Okay. Good morning again. So, Judy, Dr. Haber was saying that we are bludgeoning our students, and we are with oral systemic health, and I'm certainly doing that with my students. And I love to report to you that in reading SOAP notes, which I do each week, that I see that they are incorporating HENOT into their SOAP notes. And so it's just a matter of time and getting used to this and bringing it in and letting it be part of your practice. And I think you're going to see after we get done that it really is something that is well worth doing and will increase the outcomes for your patients. So the positive outcomes. So just in terms of thinking about pregnancy, we have lots of studies about oral health in pregnancy, and we know that 50% of pregnant women do not visit a dentist while they're pregnant or haven't in the past year. And some of that has to do with this kind of fear that we have here that dentistry is not for pregnant women, or that visiting a dentist, you shouldn't do that during pregnancy. And some of that comes from providers, some of it comes from dentists. And I think that we need to kind of get that myth out of the way and kind of move on from there and make sure that we have all of our pregnant moms visit the dentist during their pregnancy, because it's going to make a difference not only for their health but for the health of their babies. So out of that 50%, 20% have never had their teeth cleaned ever, which is, I can't even hardly think of that. You know, it's just like, what? You know, so you know, we have a very, people are just afraid. So we need to just let them not be afraid anymore and let them know that they really need to go see the dentist. And 40% of pregnant women have some form of periodontal disease. And that disease can really affect those moms and those babies, and can affect, as I'm going to show you. So we need to really get rid of that disease, and we need to be able to incorporate that oral health exam so that when you are seeing the mom, you're not just seeing, you know, listening to the baby's heartbeat and measuring, that kind of thing. We all do a full physical exam, and let's just incorporate this into our exam. Part of my message to you today is that as nurse practitioners and midwives, we are well situated to bring the message of oral health and the importance of oral health to our patients. Midwives see their patients 10, 14 times during their pregnancy. We see them during their labor, during their birth. We see them postpartum. We see them for annual exams. There's so many opportunities for us to say, okay, did you get to the dentist yet? Have you had your teeth cleaned? Are you taking good care of yourself? As well as, you know, it should be part of that visit when you ask them, do you feel the baby move? Are you feeling the baby move each day? Right? So let's just incorporate this in. HENOT is just bringing that oral exam in. I think if we start printing that out or putting it within our electronic medical record, that it will help us to remember also. So during the postpartum period, I think it's really a very opportune time for us to talk to the mom, not only about her oral health, but to talk to her about the baby's oral health. Because the studies show that if you have a mom that has a number of caries and her mouth is not well taken care of, her child is also going to have, you know, a number of caries, that she won't have a healthy baby with healthy mouth. And so we can even talk to her during her postpartum visit about how to take care of herself and take care of how easy it is to take care of that baby's mouth too. So I'm looking forward to working with all of the midwives that are here so that we can learn how to do this exam. And I think I'm going to turn this over to Dr. Moursi. Yes.
Good morning. First, I want to applaud Erin and her team for putting together this workshop, getting together all these people all in one room at one time, and all about oral health. So I think that's wonderful, and it's been a pleasure working with Judy and Erin on this whole initiative, whether it's developing sessions and training for nurses, curriculum. We've been doing video modules or designing the mannequin many of you will see, or recently we created a clerkship at Bellevue Hospital on pediatric oral health, where medical students, nursing students, dental students, pediatric dental residents are all working together providing pediatric oral care. So it's been a wonderful journey, and I look forward to continuing that. The focus of my presentation will really be about kind of what happens very early on, what happens kind of in early childhood oral health. It's a huge problem. As you can see, the extent of early childhood tooth decay is enormous. It's the #1 chronic childhood disease, 5 times more common than asthma even. It seems like every kid you meet has asthma. So it is also the largest unmet health need. So if you do surveys around the country to parents and you ask them, you know, what's the hardest kind of health care for you to get for your child, they will say oral health. And so those two factors together make it a really pressing issue. And a lot of that tooth decay, a lot of that disease is untreated. It goes untreated, and then that obviously can cause a lot of problems. So you can see a picture here. You'll see many more gruesome pictures like this throughout the morning. But this is not exceptional. We see this every day. This is not, you know, 1 in 1,000. This is fairly common and typical. So why is this important? It's, you know, there's many myths, as Julia mentioned, about oral health and pregnancy. There's many myths about early childhood oral health. Cavities are preventable. It's not just a rite of passage. It's just something that happens to you during childhood. And particularly with primary teeth, baby teeth, there's a myth, oh, they're just going to fall out anyway, so it doesn't really matter. Well, it does matter when you're in constant pain. So many of these children are kind of in a chronic, consistent low-grade pain that they very often can't even articulate. It's not like you or I have a toothache, we may be having peeling us off the ceiling. Theirs is kind of low, and they learn to adapt without really articulating it. They'll avoid certain foods, hard, crunchy foods, hot, cold foods. They'll be picky eaters. They'll be grumpy, irritable. They'll learn to just chew on the other side. You know, they do all this, and you don't really realize that, parents don't realize that until that decay is corrected, is restored, or the tooth is removed. And then suddenly you'll see this remarkable difference. So that chronic pain obviously is there. It can affect how well they eat, their nutrition. That obviously affects the rest of their growth and development physically. And also then socially. So if you're in constant pain, you're not sleeping well, you're not eating well, you're not going to do well in school, whether it's preschool or later on. You're not going to socialize well. And even young children are aware of aesthetics, how they look, and children can be cruel to each other. They can make fun of each other. So all those go into play. The number of school days lost is in the millions, number of hours of work lost by parents trying to tend to children. It's a huge problem, and not to mention even the expense that goes into this. So the expense in treating many of these children, whether it's in the dental office or in a hospital setting. So how does this all happen? Again, it is preventable, but it's pervasive. So it happens really very early on. As soon as the tooth erupts, the first, typically children get their first teeth around age 6 months. So I've seen 9-month-olds with severe decay. So it can happen very, very fast. So you have a tooth, you have bacteria, that plaque we all talk about and you hear about in the commercials, that's bacteria. And that bacteria feeds off carbohydrates from our diet. The bacteria makes acid, and the acid essentially etches a hole in the tooth, and then you have a cavity. So, and it's progressive, and you can see through here, it starts kind of with this demineralization, this etching, that turns into what we call a white spot, and then that can go deeper into the enamel, into the subsurface layer, and then eventually you have a true cavitated lesion, a hole in the tooth. And then that can progress on deeper and deeper into the tooth, and eventually involving the pulp where the blood vessels and nerves are, and that then bacterial infection can then spread through the roots into the surrounding gum tissue, bone tissue, and cause all sorts of pain and infection. Throughout the oral cavity, the head and neck, and systemically. So that's why it's important to see this as a systemic problem. It's not just a baby tooth, it's not just a cavity. It really is, as we've all going to be stressing, is that oral systemic connection. So it's really a balancing act. So what we talked about how this tooth decay is caused, and some of the factors, obviously. Some people, everyone has different bacteria, right, in our whole body, and it's certainly true in our mouth. So some people happen to have more karyogenic bacteria that are a little bit stronger and better at making cavities. We have those, and those are what we're kind of given with, but they vary. I have siblings that grow up in the same household. They'll have different types of bacteria, different levels of cavity experience in their mouth. But what we can control is the amount of that bacteria, how much it builds up, and we do that with good oral hygiene and fluoride, and also controlling our diet. And diet's really about frequency. Sure, you don't want to overdo the Oreos and the ice cream, but really the children in my practice that get a lot of cavities are the snackers. And they may be eating perfectly wholesome, whole grain, organic, natural, grass-fed food, okay? But if you are constantly bathing the mouth every couple of hours in some carbohydrate, whether it's milk or apples or whole grain bread, you still have the potential to cause cavities. And you can brush 10 times a day. It'll be very difficult to compete with that constant release of acid from the bacteria. So it's really about reducing frequency. And so that's where the sippy cupful of juice that's in the stroller comes along. That's where putting the child to bed with a bottle with anything but water comes along. You can get severe cavities in a matter of months. So obviously, if you have special healthcare needs, if you're on medications that reduce saliva, other special healthcare needs that interfere with your ability to have a good diet or a good oral hygiene. And then the makeup of our saliva. Some of us are blessed with kind of saliva that's better at competing against this bacteria and the acid they produce. It's kind of our own natural anti-cavity factor that we have. So that's kind of the balancing act between kind of the prevention measures and the factors that cause cavities. Early intervention is really where all of you come in. And the sooner we can identify children that have problems, and the sooner we can prevent them, the much better off they'll be. So I'm going to wrap up by just encouraging all of you to be aware of this, know where and when to refer, and also to be aware how serious a problem this can be, because we have a 3 to 6 month waiting list of 3-year-olds at Bellevue Hospital to be seen in the operating room. Okay, so these are children. It's too late for them. Okay, 3 years old is actually too late for most of these kids. So if we can, following the guidelines of the American Academy of Pediatric Dentistry and the American Academy of Pediatrics, see all these children by age 1, we can often prevent these children from being seen in the operating room. So I will leave you there and turn you over to Donna.
So, hello again, and I'm going to talk about integrating the oral health assessment and fluoride treatments as part of your primary care practice. And although I'm pediatric, some of the things I'm talking about really can be integrated in any clinical practice. You don't have to, you can be adults, whatever. Let me see if oh, there we go. So, one of the things that we've already mentioned is the HENOT, and Amir was talking about the health history. So one of the things we want to do is identify through a risk assessment, and very quickly we can identify whether or not the parents of young children have dental caries themselves. Have they been to a dentist? Do they go to the dentist? What are the children eating? And do they go to bed with a bottle? The things that Amir just talked about. So that's really an AAP recommendation, a quick assessment so that we know what we need to do for the plan of care.
One of the things you can do in your office, whether it's pediatric, adult, or whether you're in a specialty practice, for example, many children, like with CP, I know Fernando's here, Eduardo's here, they have multiple extra saliva, so they're at higher risk for dental cavities. So we can appoint someone to be an oral health champion, and you all have little oral health champion badges on your table. So it can be your receptionist, it can be a medical assistant, it could be one of the nurses in the office that really focus on oral health care. They provide them with some handouts. They ask the questions when they come in. When's the last time you brought your child or you as an adult went to a dentist, and documents that information for you. They can also distribute the referrals and those type of information so that you really are not taking additional time in your practice, because we all know we have 15 to 20 minutes to see a patient, history, physical, guidance, all of that. So we really have to be very efficient. So that anticipatory guidance that we can talk about, the oral hygiene, nutritious diet, prevention of dental injuries is all AAP recommendation. We can do that as providers, or we can have our oral health champion do that as part of our clinical practice. When we look at oral systemic disease, some of the things that we see with early childhood caries, we already mentioned poor nutritional intake. Children who are obese and very overweight, because they often are snacking on foods that are not healthy, they're also at higher risk for dental cavities. And then, I don't know if you looked up DeMonte Driver, he actually was one of the children that really made this initiative for oral health come to life. He was a young boy in Maryland, about 12 years of age, who had a toothache, went to needed treatment, he didn't get it, and it abscessed and went to his brain and he died. So it really is something that should not have happened, and we really should be able to find resources for the children. And that's another thing the oral champion can do. They can look at who in your catchment area will take care of children. Some of the dentists that are in the area where I practice with our students are not comfortable with young children. So to send them there, it's not appropriate. They'll see the older children, so we know that. So we need to find a place that'll see young children. So in your catchment area, the oral health champion could say, you can go to this dentist will take, like if you have Medicaid or what type of services that, healthcare services that can be provided for them. One of the things when we're doing assessments, and Jill's going to talk about one of the exams, but I'm going to look at the older infant, toddler, preschooler, and we all know they hate the tongue blade. Do not bring it out to them when you're going to do their oral health exam. Actually, we designed a step around for the oral health exam where we exchange places with the parent. Normally, you're standing at the table doing your exam this way. So if you step around the top of the table and have the mother or father step on the other side, you don't have anything in your hand, you have a good light resource, and you have a little mirror that the child could hold. You ask them to show you their teeth, they show you their teeth. It's no problem. You show them the tongue blade, they clamp down. You can put the tongue blade in their mouth and practically lift them off the table. Their teeth are holding onto it so tight. So get rid of it. And you can do a successful oral health exam on young children without putting fear into them. The other thing we can do is part of the, I actually don't have the slide there, but for the general exam, when you are on your, like if you have an EMR, you can include the oral cavity. Now, right now, if you click on it, I don't know how many of you are using electronic medical records. If you click on it, it just tells you moist oral mucosa, so that's not enough. But you can integrate in the number of teeth, or you can integrate whether, white spots, you can integrate all this information in so you could just click. So again, integrating is a very important part. Right in our EMR, it should be right up front for us. Fluoride varnish is another thing that we can do as part of our primary care prevention. In the clinic I work in, the children really go at the age of 2 now to the dentist for their first visit. So at the age of 1, we can do fluoride varnish right in our office for the children, whether they're at high risk or not. They can have a fluoride varnish application, and this tells you some of the things. Timing of it should be for by their first birthday when they have several of their teeth are in their mouth. We can do it again if they're high risk at their 18-month birthday, 18 months old, and then again at their 2-year-old visit. or if they go to the dentist, they can have it done there. It is a billable, we can bill for fluoride varnish application in the office, and I put up the Medicaid code for you, but it can only be submitted if it's a physician, a nurse practitioner, or a dentist. So we can only bill for the service provided by those providers. It should be a part of our routine practice. It only takes a few seconds to really do the oral health exam and to apply the fluoride varnish. So it should just be routine part of our care. The other thing is establishing the dental home for the children. And, the dental home is someplace where the parents or children can go to be very comfortable in providing the care for them. We can, again, if the oral health champion in your office provides names of dentists that they can choose, we would like it by 1 year of age. If they're not able to do it, some of the parents cannot afford at that point. If they're on Medicaid, we can, and then we can help them establish it. Definitely by the age of 2 or 3, they should have a dental home where they're going to the dentist on a regular basis. We can also make referrals based on our health risk assessment that we did early on, so that the children are referred appropriately to the dentist. The last thing I just want to mention, this little baby here was one of the newborns we saw. We did a newborn study, Jill and I and several other students and faculty, and we did it at Bellevue, where we went in and educated the mothers in the newborn nursery about oral health care. And then we did a follow-up study, hoping that they would not take the bad habits. And some of the bad habits, Amir mentioned, like vertical transmission, when they put food in their mouth, and sometimes you see on the news some actress was chewing the baby, bird feeding, and then putting the food in the baby's mouth. Well, that's ridiculous. They're just giving the children the organism to increase dental caries. So we tried to stop those practices. Other things that they do is they drop a pacifier on the floor. I don't know how they could do it. Put it in their mouth, wash it out, and put it back in the baby's mouth. Well, again, a ridiculous thing. Or spoon feeding. They take up the spoon. They're eating the baby food. We don't need to eat baby food, but they're tasting it. We don't need to do that. So, or if they give them their own spoon and give them their own plate of food. It could look just like yours, but people don't realize it. And if you look around on the plane, wherever you are, people are doing it all the time. And, so we want to prevent that. So we started it then. Julia mentioned she can continue it as part of the midwives, and we should continue it in our first visit, which is 2 to 3 days post-hospitalization, and then at significant visits as the children develop teeth at 6 months, and then again a year, where we're really focusing on oral health care for them. Okay, and I think now, Jill.
All right. Good morning. I always like to tell this story. My first interprofessional experience was over a glass of wine. Okay. Soon after the College of Nursing and the College of Dentistry merged, there was a meet and greet so we could meet other faculty, and I happened to meet Donna Hallas, and I found out we had a few things in common. We both liked white wine, but more importantly, we both worked with children. And from that meeting, we started meeting on a regular basis and collaborating. And we've done, as she mentioned, research together. We've written some articles together. And we've also developed a program where her PNP students rotate with our dental students out in the community. And I have an opportunity to have them work closely as a team when we go out to Head Start centers, looking at children from about 6 months of age to 5 years of age, doing an exam, lifting the lip, looking what's inside, getting them to understand and kind of get a feeling of primary teeth, how to put fluoride varnish on, and so that they're really hands-on working with our dental students and kind of learning together. They each teach each other something, because her PNP students are wonderful when it comes to behavior management, which our students are still learning. So again, great collaboration. I think Donna and I kind of coined the phrase about step around, and that's very important because you really can't look at the mouth fully until you're sort of, if you're the operator, you're behind the child and you're peering in, and you have that caregiver, parent or caregiver, kind of in front of you and seeing what's going on. Now, whether you do it on your examining table, where, again, you as the primary provider step behind and the child's head is sort of right, would be almost in your lap, or what we do in our dental school or when we're out in the field is this knee-to-knee position. And mind you, our dental clinic has many, many dental chairs, but we don't use them for the very young children. So we put 2 chairs together so that the provider and the caregiver or parent are facing each other, and we explain to the parents specifically how we want them to position their child. And I know Amir and I have trained general dentists about this, and we've done a lot of videotaping and get a kick out of it, because you really have to explain to a parent what you want, because parents are so used to, and here, look, here's my child, they're facing you. That's, or they sit them on the lap facing you. So we're very explicit explaining knee to knee, you're gonna hold the child and give them a hug, and their head's gonna go down on the primary care's, the person who's looking in the mouth lap. This is a great opportunity, again, for you to really see in the mouth and lift the lip and look around what's going on. But it's even a more important experience for the parent, because they're actually able to see what you're looking at. Sometimes parents have never looked in the mouth. I speak to a lot of parents and they go, they're 3, they can brush on their own. Well, a 3-year-old can't even tie their shoes. Now they have Velcro, so they don't have to tie their shoes. But they haven't looked, so it's a great opportunity to show them. Oh, look, Mom, some of the new teeth are coming in. Can you see them in the back? Or do you see the front teeth, coming in right here? Are you cleaning? It's a great opportunity to start some exchange. Are you cleaning the mouth? Are you bottle feeding? Are you breastfeeding? Do you put the child to bed with a bottle? What's in the bottle? Does the child use a pacifier? All this information that you can start talking to the parent about while you're looking in the mouth. And when I say lift the lip, don't be afraid. Because very often if I tell a child just to open big, sometimes their front teeth are covered. And it looks like, oh yeah, their teeth are probably there. All of a sudden, you lift the lip and you can really see what's going on. You can see soft tissue. We're not just always looking at teeth. And when you join us, if some of you join us at our table later, we have this mannequin that's very lifelike, that has oral lesions. It has soft tissue lesions, hard tissues, so you'll have an opportunity to really see what you're looking at. But don't be afraid, lift the lip. You can see if it's plaque, that maybe they're not brushing, you see some white stuff, maybe you take some gauze and try wiping it off. It's not coming off. So it's not where it's food debris, because sometimes that happens. You're looking for white spots. Do you see anything, or brown spots? What looks unusual? What looks out of place? On the soft tissue, are you seeing, is it, pink? Is it stippled? Is it, do you see bumps? Do you see something, a white patch, a red spot? That's not normal. So you're really getting a good look. Also a great opportunity with very young ones, they just have a few teeth. I recommend to parents just use a wet washcloth. They don't have to get anything fancy. Those first few teeth, just kind of start wiping them off. And then they do have toothbrushes now that are for every age imaginable. They have first brush and second for the next age group and so on. But again, putting a little very tiny, tiny bit of toothpaste on and getting in there and cleaning the child's mouth at least 2 times a day. Because again, parents are going to be like, well, they only have baby teeth. And as you saw from Dr. Moursi's pictures, those primary teeth are so important, and we need to emphasize that to parents. And as you can see by these pictures here, the picture on the upper left, you're starting to see, let's say I saw that child and I used some gauze and I wiped the teeth. It wasn't plaque. I'm beginning to see around the gum line some white spots, and I can point that out to parents saying, that's like the beginning of a tooth demineralizing. It's the beginning of a tooth that has some issues. We need to really get in there and clean. And are you using a little fluoride toothpaste? As it progresses, you look at that picture on the upper right, you start seeing some pitting and some picking up some stain. A lot of times you're going to have gloves on. A lot of times I end up using with my gloved hand, running it across the tooth. Do I feel it rough, or does it feel smooth like an ice skating rink? Or am I starting to feel where the tooth is actually starting to rough up and we're starting to get a cavitated lesion? And of course, you look in that picture on the lower left, and it's obvious there. You lift the lip. You can also see an abscess right above that tooth that you see looks very dark. You see a little dot up there and an abscess. So very important to look at that soft tissue as well as the teeth. That lower right, that's the kid who, if you don't lift the lip and you just have them open, you're going to think, I don't see those teeth, so maybe they're already exfoliated. And actually you lift the lip and look, they're just broken off right at the gum line. And all these kids are 3 and under. And you heard Dr. Moursi mention about this waiting list at Bellevue and at many other hospitals for children this young that need, I mean, with something like that, they can't just sit in the chair and have, procedures done one after another. So this is a child that has to go and be sedated and be in the operating room. So really important. Now I know on your tables you have some wonderful handouts, and you have one there called Lift the Lip. It's in English and in Spanish. And it's great for parents because it really, I love the little Lift the Lip here, but talks about cleaning daily and using fluoride and getting to the dentist by age 1. Not putting the child to bed with a bottle, weaning them from the bottle 12 to 14 months of age, and talking about that first visit at age 1 and getting them into a dental home. So I look forward to you joining Dr. Moursi and I at the table and lifting the lip. I'd like to bring up Madeline Lloyd.
Thank you, Jill. Good morning. So my morning started with my 2-year-old this morning coming into bed for a cuddle, and I thought, isn't this great? He had his blankie, and after about 10 minutes, suddenly he hysterically started crying. He was drooling, and he had his tonsils and adenoids out 2 days ago. And it had been about 10 hours since his last Motrin Tylenol dose. And I just thought, oral systemic connection, I'm living it and breathing it. Not only do I live and breathe it at work, but it's also in our daily lives. And I was never more grateful for Motrin this morning and about 20 minutes of cuddle time or hysteric. Not even the lollipop was working. So I think as we transition from children and as they grow up into adults, we still want to really think about that oral systemic connection. And what does that mean? Big words, what does it mean? I'm going to do very simple messages today because I know it's early. The good news is we don't have to be a dentist to distinguish between healthy disease, healthy gums and disease. So I'm not a dentist. I love my dental colleagues and they have taught me a lot about oral systemic, but you can see from here, the top healthy, the bottom not so healthy. My other take-home message for you will be that most of the disease and the oral pathologies that you're seeing will be before the pharynx. Do not pick up the tongue blade. You can actually leave it behind. Instead, why don't you use a 2x2 gauze? And I'm going to show you in a little bit why that's much more effective way of examining the oral cavity than just going straight to a pharynx. And guess what you've missed? Look at the photo on the bottom. You've missed receding gums. You've missed calcification of plaque, that white patchy bit. You've missed these dental caries. You've missed the periodontal disease. So when you see this type of mouth, you actually start to wonder, well, what's going on systemically? And this is where you start to really take a good history. And as you're taking the history, you're thinking about, does the patient have diabetes? Is this HIV? But even with a controlled heart regimen, you can still see oral lesions and oral pathology. Is this an STI? The person comes in, you're just thinking waist down. Well, what about syphilis? What about things that can be happening? And I'll give you an example in a minute of an STI. You're also thinking about medication management. Are they on things that give them a dry mouth? You're thinking about, this is inflammation in the mouth. Where else in the body is there inflammation? Does the patient have known coronary artery disease? Do they have any mental disorders such as depression, eating disorders? These will all show up potentially in the mouth. What about substance abuse and tobacco? Tobacco and particularly alcohol. What do we know about that? We know that about 80%, there's an 80% progression of oral cancers if you've had heavy drinking and smoking. So when you're eliciting that history and you have somebody, my example, I worked with a dental hygienist on Monday. We walked into the room together and you could smell this fruity sense of something's in the air, and it wasn't pleasant, and it was coming from the patient's mouth. Well, she was 31, not overweight, and I'm thinking, all right, so I said to the dental hygienist, what do you think? She goes, well, it's either diabetes or alcohol. So we took a history. She thought that having 10 shots of vodka on a Friday, Saturday night with her husband was normal behavior and was not interested in cutting down. So again, just being able to elicit the history and put the mouth together, and not even the tongue blade at the pharynx yet. So what do we do with the 2x2 gauze? I only had 5 minutes, so I picked oral cancers because you see on the lateral part of the tongue. So even if you say to the patient, didn't we all learn, poke down the tongue, what are we looking for? It's actually the lateral area of the tongue that is the most prevalent for oral cancers and oral lesions. So if you do nothing else, grab the gauze and move the tongue side by side as you lift and lower the lip, as Jill was talking about. And you're going to see that lesions from cancer look red or almost white. And anything like that, just refer out. You don't have to know how to treat it, but anything that looks abnormal. The other thing in your history, ask them, when was your last oral exam? You would ask a diabetic about when was their last foot and eye exam. Well, ask about when was their last oral exam as well, as we know the link with periodontal disease. So I took oral pharyngeal cancers, that what types of things on history would you necessarily see that might point you into thinking oral cancer? So hoarseness of change of voice, persistent sore throat, and earache. So you look in the ear, well, don't forget to look at the lateral border of the tongue. Pain or difficulty swallowing that's persisting, pain while chewing, a feeling of this lump in their throat, and it's usually around the anterior triangle of the neck. And that's where you want to feel and palpate for lymphadenopathy. And obviously if there's an ongoing swollen lymph node, that should be biopsied because that could be linking to oral cancer. So the buccal mucosa is a very interesting area. Don't forget to look at it. And if you need, then you can go to the pharynx and see what's going on there. All right, but thank you.
Speaking about geriatrics, I'm going to have to put my geriatric glasses on to see my own slides. They're so small on the monitor here. Thank you for having me. It's my pleasure to come speak to the group. The diseases we're speaking about are a continuum. The fact that we're going to speak a little bit about geriatric oral health, we start out with healthy teeth by nature, and we talk about caries, periodontal disease, and oral cancer as we grow older become greater issues across the entire skill set and the entire aging range. And though I'm going to focus in a very narrow band in a moment, I need you to recognize that oral cancer and tooth decay are and periodontal disease are all issues that are associated, and we're not asking you just to look in the geriatric mouth or the young mouth for, the young mouth for caries, the middle-aged mouth for cancer. We need to look for everything in virtually all mouths. I'm also going to frame this in a slightly different mechanism and talk about it as being a workforce capacity issue. And I'll start right out by saying we have a problem with older adults with their mouth. We're getting older. Not only are we getting older, we're getting older while retaining our own teeth. That's great. But our teeth that we are retaining have more complex work in it that makes it more difficult for us to maintain and has more difficulties associated with it. In 1960, average life expectancy was 67 3/4. 60% of the population had no teeth. Not a big problem. It's why Social Security was at age 65. Sure, give it to them. They're all going to be dead soon. I mean, that was the logic of what went on there. This is a very big problem. The repair and reconstruction and the implants and the maintaining of teeth have changed our aging for a wonderful aspect. But there's also an incipient disease that's associated with it. And what's associated with it is when you get on Medicare, you have no dental coverage. When you retire from your job, you probably will lose your dental coverage. So we put more expensive work in a group that is less capable of maintaining themselves and less financially secure to do so. They get a foot infection, they go to the hospital, they take care of it, they get a dental infection, and they writhe in pain rather than go see the dentist because it may be the few discretionary dollars they have to spend. This is actually quite a problem. So 70% of long-term care patients are on government assistance. That's wonderful, but the percentage of adults that are in long-term care is minuscule compared to our aging population. 20% of our population will be over the age of 65, which used to be old. I consider it pretty young right now. Over the age of 65. In just another 8 or 9 years. That's a tremendous shift in demographics. Administrative overhead is very high for dentistry and for dental care. Dentists don't like using Medicare, Medicaid. There are lots of reasons why we don't do care on patients, but it gets even worse. If we ask about who's available to do the care, there are only 12 dental programs in the United States that train dentists as specialists to do geriatric dental care. A physical impossibility to provide it in numbers and say, and send them out to the geriatric dentist. Instead, the Commission on Dental Accreditation has said that all dentists must be capable of treating in a general realm. But that doesn't even touch the tip of the iceberg. And I'll use one example of an oral systemic connection to just drive this home. So you've heard about periodontal disease. So in a long-term care facility, what is rated as the #1 cause of death from infectious disease? Pneumonia. Where do over 50% of these pneumonias what do they actually have in common? They have periodontal disease, high plaque load, and high disease load. It's a bidirectional disease where, coming from the lung, we wind up infecting with Pseudomonas and Klebsiella and staph in the mouth, and the mouth comes back and reinfects, particularly in our patient population that has difficulty swallowing. Aspiration pneumonia becomes quite common, and it's associated with oral dysphagia. Now, it's actually too late, and though there were some comments that it's easily controlled, periodontal disease is not easily controlled, but the amount of periodontal pathogen available to go down somebody's airway when they're having difficulty swallowing and breathing can be. But we can't count on calling in the dentist. I wish I could count the number of times as an attending at a hospital out on Long Island, where I was a residency director at one time, that we were called to the intensive care unit with the request, there's a terrible smell coming from the patient's mouth, they're intubated, they're on a vent, what's going on with all of this? We open up the lips. We did the same thing all the time. We carried a toothbrush up to the ICU. I mean, we put it in our pocket when we got the consult request and we went upstairs. And you pick up the mouth, and here was a mouth that hadn't been brushed for almost the entire time that the patient had been sitting in an intensive care unit. And somebody's going to extubate this patient. So this is the key to the problem, but the solution to the problem isn't in dentists. It's actually in this particular group here, as we sit and we look at this situation, we need to find a method of surrounding dental care, having a team of people that start approaching. Our senior citizens don't come from only one location, and we're not only speaking about them in the intensive care unit or in the long-term nursing facility. We need to talk about them when they're homebound and unable to get out, when they're living independently, when they're living in environments that have large numbers of seniors in that same environment and they're living quasi-independently. We need to take active roles in doing this, and it can't just be through dentists. We have to elevate the information that's handed out and deal with large numbers of issues all at once and start pushing the dental issue before they wind up in the long-term nursing facility. So for me, I need to call upon this to be our moment to have interprofessional care at all levels. Whether we're talking about speech pathologists, whether we're speaking about dentists, whether we're speaking about nursing, respiratory therapists, we need a larger team approaching this problem because dentistry, as it's currently laid out, can't handle it, and it will result in better outcomes of care for people if we approach it earlier. So, with that being said, I will pass this fast dart off to the next person. Off to Candice. Thank you.
Thank you. Very good. Thank you all for coming, and thank you, Erin, for inviting me to speak on this panel. I bet you're all wondering, what role does a psychiatric nurse practitioner play in oral health care? Why did I even get on this panel? Well, I'm going to convince you in the next 7 minutes that our role is an extremely important role. We don't do health assessments, so we don't look into people's mouths. We don't treat diseases. So what role do we actually have? Let me just make sure I can put this up here. So I'd like to start with the psychiatric patient, and then we're going to move on to the patient that we could all relate to. So if we look at the psych mental health patient, there is an increased vulnerability to dental neglect and disease. They have a higher rate of anxiety. They have a higher rate of dental phobia. They also have a lot of side effects from psychiatric medication. Any medication that blocks acetylcholine, which really covers just about all of our medication, anticholinergics, atypical, typical antipsychotics, mood stabilizers, benzodiazepines, stimulants, across the board, they all cause dry mouth. And if you have that, you have an increase in dental caries and periodontal disease. Third, there's a low priority. Many of our patients are poor. Many of our patients are homeless. They're less apt to seek dental care. And if they do seek dental care, they make irregular dental appointments. They're more apt to cancel appointments. Some of the studies show 40 to 60% of all psychiatric patients, once they make an appointment, actually cancel that appointment. There's a high prevalence of substance use, as Madeline related before, and people with substance abuse definitely have a higher rate of dental disease. There's low mood and low motivation with many of our patients. And the last, which I think is most important, is lack of services. We don't have services. That's one of the biggest problems. Just last week, we had a big discussion in my group about clients that were at Joanne's site who have such poor dental care and they can't find services. Let's face it, dentists don't like psychiatric patients. Why? They're harder to work with. They have more pain. They cancel more appointments. And I could go on with the list, but they are more difficult patients. And as the previous speaker said, geriatric patients are the same. My particular dentist will not deal with geriatric patients, nor will he deal with psychiatric patients. So it's a population that's has a lot of difficulty receiving care. Let's look for a minute at the particular diagnoses, schizophrenia and other psychotic disorders. This population, although it's a small population, 1% of our mental health population, very, very difficult in terms of dental health care. First, they have avolition, which is the inability to set goals and move forwards to achieve those goals. And that they all also can range to different disorders, hallucinations, delusions about dental care. Eating disorders. Madeline addressed eating disorders. 75 to 90% of all patients with bulimia will have, within the first 2 months, dental erosion. 80% of anorexic clients will have a decrease of calcium, which causes some of the problems that Julia addressed earlier with our maternity clients. Substance-related disorders. Now, I could show you some gory slides here, and I was going to, but Erin restricted me to 3 slides. But I think some of our most difficult clients are our clients who use crystal meth, heroin, nicotine, and cocaine. All stimulants which cause drying of the mouth and a numerous amount of problems. Depressive disorders, Madeline addressed that. Patients who are depressed have poor oral hygiene. They just don't have the energy to move forward to do the things that are necessary. Bipolar patients, and obsessive compulsive patients, sometimes they brush too hard and destroy the gums, destroy the enamel. BDD, body dysmorphic disorder, which is an area that I specialize in. These clients will go for whitenings numerous times, destroying the enamel. They also will brush very vigorously. My brother's an oral surgeon, and he has referred many patients to me who get dental surgery to do things that are really not problematic, restructuring of jaws and that sort of thing. But what I really want to talk about today, because I was only allowed to pick one systemic disorder, and I had a hard time because there's a lot of them. But I selected anxiety and dental phobia. Why did I select this disorder? Well, it's something that all of us in this room can relate to. In fact, 75% of all adults, so that includes 75% of you in this room, have mild to severe dental anxiety. We talked about patients not going for care. This is one of the largest reasons why patients will not go for care. And out of that 75%, 10% actually have an extreme form of anxiety known as dental phobia, which is actually a diagnosis in the ICD-9 and the DSM-5. And children, 15%. Have dental phobia. So we're talking about a large number of people. Now, what happens when people don't have this disorder? Well, they don't go for treatment. So we really have to do something about this particular population. What are the types of dental phobias? Well, they can range from things like fear of drills, somatic complaints like fear of gagging, fear of vomiting, or even situational, fear of smell. So there's many, many types of dental anxiety. I told you the prevalence of both anxiety and dental phobia. 75% of all adults have mild to severe, and of that number, 10% of adults have dental phobia. What are the causes of anxiety and dental phobia? Well, some of it can range from the media, or what we hear as a child. How many of you heard as a child, "It's so exciting to go to the dentist," from our parents? None of us have heard that. Did somebody hear that? Okay. Well, most of us heard much more negative kinds of comments. So it can range. Also, the media, how they display dentistry in television and the movies, very negative. In general, very negative. But it could also increase to trauma. Trauma in dental offices, trauma with dental personnel. So the list goes on and on. So what is our role? Now, I'm just talking here about the role of the psychiatric NP in anxiety and dental phobia, because our role is much broader with all of the other disorders that we do cover. But we can use an assessment scale. There's instruments that are out there that are in the public domain. I gave you two of them, the DAS scale and the MCDAS scale. As I said, they're in the public domain, so you could just Google those. Or we could just, all of us, ask in our history on a scale of 1 to 10, how frightened are you to go to the dentist? Very simple question. We all ask about who your PCP is, but what we could just add that question. And what do we do then for it? If we determine that a patient is not going to the dentist because of dental anxiety or because of dental phobia, what do we do? The first line treatment is psychotherapy. And as all of us in psych know, when you provide psychotherapy, you want to conceptualize what the problem is. So if the problem is a simple problem such as a learned helplessness or learned to be fearful of dentists or anxiety, we could do behavioral interventions or cognitive interventions. So the most common behavioral interventions are things like relaxation, systematic desensitization, where you do a hierarchy and couple that, pair that with relaxation exercises, or we can do exposure therapy, which is a little bit more difficult. We could also do cognitive therapy. Now, cognitive therapy on one level is pretty simple to conduct, especially when you're looking at automatic thoughts, such as, well, I'm afraid of the dentist because the drill might slip. Well, that's a catastrophic thought that we could easily dispute. Where it gets more difficult with cognitive therapy, where you really need to have a very well-trained clinician, is when the issues are much deeper, which they usually are. They're usually cognitive core schematic things, such as I'm afraid of life in general. So that's a much more complicated intervention to use. And then for those who really have a lot of trauma, we could do things like EMDR, Gestalt therapy, emotion-focused therapy, and more of the in-depth psychotherapies. Medication and referral, the last two things. How many of you are very apt to pick up a prescription pad and write a prescription for alprazolam 0.5 to take 30 minutes before the dental visit? I want to warn you, do not do that. It's counterproductive. It's also counterproductive for fear of flying and many of the other things. Study after study has shown that if you give somebody a benzodiazepine before dental surgery, their anxiety will actually increase immediately afterwards as well as in the long term. Why? Because you're providing the mechanism of avoidance, which is the worst thing to do with anxiety disorders, whether it's separation anxiety or dental anxiety or fear of flying anxiety. You do not want that client to avoid experiencing the anxiety. So that's a real take-home point. Refer to a psychiatric nurse practitioner to provide these different types of psychotherapies. And it's been very hard for me to develop a collaborative relation where I live in Flemington, New Jersey, because we're not used to collaborating with you, and they're not used to collaborating with us. But I have a list now of oral surgeons as well as dentists who are referring to me. In fact, I'm almost having a specialist practice in working with dental clients. So for those of you who are looking for a specialty practice, it's a very lucrative one that you can go into. So with that said, I want to turn this over to Dr. Brennan, who is going to talk about acute care. Thank you for listening.
Okay, welcome again, everyone. My name is Mary Brennan, and I'm talking about the nutrition, oral, systemic health of hospitalized adults, what I call the NOSH initiative. And I say a nice Irish girl speaking just a little bit of Yiddish for you this morning. Oh, thank you. Perfect. So the story of hospitalized adults actually begins prior to their hospitalization, where many adults with poor oral care suffer profound nutritional deficiencies. Whether it's missing teeth, whether it's dentures, or patients without teeth, they all have serious nutritional deficiencies. For example, the patient without teeth consumes more sweets, fewer fruits, fewer vegetables, and all of that pattern leads to the development of comorbidities such as hypertension, diabetes, but also contributes to the acute care of problems such as coronary artery disease, strokes, etc. What is known about patients who are then admitted to the hospital is that 20 to 50% of patients are malnourished upon admission to the hospital. Of those patients, 70% will experience a decline in their nutritional status during the hospitalization, and what's most concerning is that many providers do not know that they are malnourished upon admission, that they don't know that they're suffering a nutritional decline in the hospital, and they're being discharged malnourished as well. This is a huge problem, and one of the big problems is that providers do not think nutrition is part of their purview. Oftentimes, the nutritionist is relegated as an ancillary member of the team, or sometimes not even a member of the team. Some of the factors that contribute to poor nutrition in the hospital are illness-related factors such as nausea, vomiting, and diarrhea that accompany illness. Also, in addition, are the pre-existing oral health problems, and then just some of the procedures for surgery. For example, it's not uncommon for a patient who comes in for surgery to be NPO for the surgery, then to have 4 or 5 days of not eating after surgery. Patients cannot heal when they don't take in food. And there are a number of providers who are interested in prescribing the beta blockers, the ACE inhibitors, where in fact food is it's necessary food of life, and it is necessary for healing. So there was an article that was written in the New England Journal of Medicine in 1980, and it said, the title of it was, "Nature Castigates Those Who Do Not Masticate." But what about those individuals who can't masticate because they don't have teeth, they have ill-fitting dentures, they have mucositis, xerostomia? There are so many factors that impact their nutritional needs in the hospital. In addition to that, the GI tract, if you don't take in food, your GI tract atrophies, and many of you know that 80% of your immunoproteins are synthesized in your GI tract. So if you're not eating, you're not producing or contributing to a healthy immune system. This disturbs the balance between the oropharyngeal tract and also the immune status. For example, if you do not take in proteins, the normal border between your, the bacteria in your oral cavity and your immune function is compromised, and bacteria tend to translocate, just as Dr. Wolff was mentioning earlier. Some of those bacteria that are in your mouth, and there are billions. A healthy functioning immune system will prevent those bacteria from going into your bloodstream. An example is Streptococcus pneumonia. Streptococcus pneumonia is a bacteria that lives in your nares and your oral cavity. It is the #1 cause of hospital-acquired pneumonia, but it's also the #1 cause of community-acquired pneumonia. Something that affects patients who are acutely ill and critically ill is this concept called hypermetabolism, that patients with acute illness actually not only require nutrition, but sometimes the nutritional needs increase by 100 to 130%. In fact, patients who have burns require 130% more protein and more calories. Sometimes they're not being fed at all for long periods of time. This contributes to a 2 to 3% or 2 to 3 times the increased risk of C. difficile. And as you know, C. difficile has a 20% mortality rate associated with that particular infection. There is a 4 times increased risk of developing spontaneous wounds, not only decubitus ulcers, but just spontaneous wounds. And there is a 5% increased risk for those patients who undergo coronary artery surgery to have coronary artery, a sternitis, what we call, an infection of the sternal wound. Those patients who do not receive nutrition actually have longer lengths of stay. They have increased morbidity and increased mortality. Part of the problem is the providers don't even realize this. What we're calling for in the NOSH initiative is that, as my colleagues have mentioned, that we need greater collaboration among all healthcare providers, that the traditional notion of the team has to change, that the patient has to become the center and an important member of the collaborative team, but we also have to include nutritionists as part of the healthcare team. The nutritionists cannot do it by themselves. Every time I lecture to students in acute care, when they talk about nutrition, the impulse is, let's consult a nutritionist. But sometimes there's one nutritionist for 100, 200, 300 patients. They cannot follow up on the daily assessment and evaluation of those patients. So a nutritionist has to be a member of the team, but the providers actually have to look at nutrition as one of the most important elements of providing care. Dentists, typically, dentists are almost never considered part of the team, but I would say we should start to think about including dentists earlier on. These are patients who have pre-existing nutritional deficiencies. These nutritional deficiencies worsen in the hospital, and many patients are discharged to the hospital without a regard for oral care at all or nutrition. It's amazing that patients even recover when we think about this. So I know that this next decade of focusing on oral health is really going to have tremendous impact on our patients. And I think number one is increasing awareness for all of our providers. Thank you very much, and I will now pass it on to my distinguished colleague, Dr. Dorothy Wholihan.
Hello again, everyone. Well, I do end-of-life care, and my name starts with W, so I'm used to being at the end of the line. Okay, so I know that we've kind of come full circle here. In the last 60 minutes, we've gone from birth to death, and there's probably a couple of reactions going on. Half of you are thinking birth to death in 60 minutes. How did that happen? Was that all it means? I'm now driven you into an existential distressful situation based on oral care. The other half of you are thinking about, oh, thank God we're up to death, because if I have to look at any more disgusting pictures of teeth, I'm going to die myself. Today I'm going to talk a little bit about palliative care. That's what I do for a living. And the first thing, of course, that we need to talk about and acknowledge is that palliative care is not just care at the end of life, okay? Palliative care focuses on quality of life. It focuses on aggressive symptom management. It focuses on helping people with that tricky business of trying to figure out what their values are and what they want to do with themselves as their health status changes, and matching the treatment to match their values. That said, I look at oral issues and oral cares and lots of mouths from patients who are in the intensive care unit all the way into a hospice setting. So palliative care crosses borders, so you're all doing some of this now, no matter where you are. If we look at oral issues in terms of the impact it has upon quality of life, and this is where, as an educator, at the end of the day, I get to wake you up and ask you to participate. I want to ask you, what do you think comes to mind when you think about the mouth, oral issues, and impact on quality of life? And you know, if you don't volunteer, I'll have to call on you. Ideas, somebody. How does your oral status impact your quality of life? Okay, talking and eating, absolutely. So how you take in food, how you communicate with other people. Somebody else. Pain and comfort, absolutely. Okay, so we can even stop right there and think about it. If I asked everybody at this forum today to think about the end of their life and think about what would be important for them, pretty much everybody is going to say, I don't want to die in pain and I don't want to die alone. And yet, if you have a yucky mouth, if you have really bad oral issues, both of those things are going to happen to you. So let's make sure we think about the kinds of things that get impacted with people when their oral status is suboptimal. You want to leave the world with dignity. But when your mouth is crusted over, when you have bad breath because your mouth is not clean, then you can't have a sense of dignity, and you can't have a sense of intimacy, and you can't communicate. You can't hug and kiss and do the things that you need to do with the people that you have at your side, okay? The other issue then becomes, if we think about it, how do we deal with comfort issues? Okay, we need to make sure that we're so busy looking at the whole aspect, that your cancer pain or your breathing, that we're not looking at the comfort that's related to your mouth. Okay, so there's not a lot of literature out there in terms of oral care and palliative care. There's not a lot of palliative care literature out there, although we are evolving. I took this survey, it's a little old, but I wanted to put it up there because it points out that the issues that patients experience at the end of their life are very similar to the ones they experience all the way through. The medications that we use to control symptoms, the opioids, the anticholinergics for secretion control, create the same xerostomia that you see all the way through the lifespan. And so some of these issues are as important at the end of life as they were earlier. One of the things that I think is most concerning about this study is that it was a survey, it did exams and interviews, but it also surveyed people about how important the status of the mouth was, and the patients rated it as very high, but those in charge of the hospices, those who are in charge of money and allotting resources, didn't think it was all that important. And so that's really kind of a call to action for those of us who have some influence in institutions. So if we think about oral issues at the end of life, oral hygiene figures really prominently, right? It's really important, and yet in institutional settings, and 75% of us will die in institutions, hospitals or nursing homes, unfortunately, most of the oral care is relegated to unlicensed professionals, right? Probably among the most disenfranchised members of our healthcare team. So how often do the nursing assistants get the kinds of continuing education that they need to do the care that's important to us? So as leaders of the team, finding those champions and educating all of our staff is really, really important. The other aspect of this slide that's really important is the whole issue of food and feeding at the end of life, okay? Nutritional issues become somewhat problematic because patients lose the ability to take in food in the same way that they used to. They have GI problems, they have mouth sores, they're not capable of swallowing. And this becomes a really distressful situation for patients, but also largely for families. Because we know that our cultural makeup makes many of us, depending on our ethnic background more so than others, thinking about food and giving of sustenance as caring. And so part of what we need to do is to help families substitute other caring behaviors for the giving of food. And so oral care is where that can come into big play. And we spend a lot of time working with families and teaching them how to care for their loved ones' mouths towards the end of life. The other piece of this is just really kind of interesting for what I do for a living, is palliative care, perhaps more than some of the other advanced practice specialties, really is a systems-oriented role. So because of the evolving nature of the specialty, and because many of us in palliative care work as consultants in healthcare institutions and homes and stuff, we are looking at systems issues. We have a larger educational role, I think. We are more involved with things like quality improvement than some of our counterparts. And so we have this real responsibility then to take oral care and move it into the wider system. And so making all of the changes that we've talked about all the way down the line continue in the end of life. I know my students are kind of probably tired of hearing about oral care as much as they do, but the one thing that someone says to me the other day is, well, of course I do HENOT. It's so much easier to pronounce than H-E-E-N-T. So I would like to end there and tell everyone thank you for this wonderful panel, and I'm looking forward to continuing our conversations.
I want to say thank you to this wonderful panel, too. You did a great job, and you stuck with the slide maximum and the times, and it's 11 o'clock. We're right on schedule.